Everyone, my name is Ross Wallace. I'm a principal at Santis Health and an advisor to the Resilient Healthcare Coalition. It's my great pleasure to welcome you all here today for a conversation that we've entitled A Decade of Data and Decision-Making between David O'Toole, President and CEO of CIHI, and Saäd Rafi, former Deputy Minister of Health and Long-Term Care with the Ontario Public Service. We'll be starting momentarily just as we see our participant numbers climb, and we'll be back with a few details about the session to follow in about a minute or two. Thank you. Okay, let's get started. First, a very quick comment about the run of show for today and a little bit about housekeeping. So as I think you all know, this event is a fireside chat, as we've characterized it, between David and Saäd. There will be a moderated Q&A session afterwards. So there will be an opportunity for you to submit your questions for that Q&A conversation at any point during this webinar. All those questions will come to me, and I'll have an opportunity to identify the things you are most interested in hearing the most about and feeding them to Saäd to make sure that we can maximize the time we have together. So we'll be monitoring those questions that come in and making sure we can get to as many of them as possible. We're also recording this session, and a recording will be shared with all of you who are here in the next 24 hours or so. So I think without any further ado, it's now my absolute pleasure to offer the opportunity to Eva Villalba, who is the Executive Director of the Coalition Priorité Cancer au Québec and a co-chair of the Resilient Healthcare Coalition, to offer some introductory remarks. So Eva, to you, please.
Thanks, Ross. So welcome, everyone. The Resilient Healthcare Coalition is really happy and honored to host this important conversation, especially since the Resilient Healthcare Coalition was really born during the pandemic at a time where I think that the importance of real-time data really became apparent across the world, across Canada, across the world. But I think in Canada, we really saw what a difference it made. And from the beginning, the RHC has really, as one of its main pillars, focused on optimizing the use of healthcare data, but also reinforcing the connections between data, between access, between how it impacts patients. And as a patient advocacy group in Quebec and working across Canada, patient advocacy groups have really been a strong voice for the necessity for really good healthcare data to inform better healthcare decision making. And so we're really happy to bring this special webinar with David O'Toole after 10 decades, where we're eager to learn, what were the main takeaways? What can we learn for the future? The challenges and opportunities, how they were overcome. In Quebec, in my province, we've actually really been involved in the new Quebec health data bill and really advocating for the impact of health data. It's not just for data nerds. It also really impacts real people. And I think that's a recent realization. And that's why, at the beginning, perhaps data and healthcare was a bit more of a niche subject, but now more and more people are realizing how it impacts our daily lives. So we're really excited to have Saäd Rafi interviewing David O'Toole and hearing about how that really what we can learn to take it forward and really apply it to the future to build more resilient and I would say even value-based healthcare reform where the impact on patients is really at the front and center of healthcare decision making. And so finally, before I pass the mic back, I think I would really invite you to think about your questions, because one of the things that the Resilient Healthcare Coalition has been really good at doing is bridging and enabling, convening all the stakeholders, allowing these really thoughtful conversations that go beyond buzzwords and that really kind of dig deep into, okay, what's next? Like, what have we learned? Yes, but now what's next? So think about your questions, and I think it's going to be a really exciting webinar for everyone. So back to you, Russ. We can't hear you though.
Sorry, Eva, and thanks so much, everyone. So I will just quickly introduce Saäd and David, neither of whom need particular introductions, and then we'll move directly into the fireside chat. And then I will unmute myself and mute myself again. So Saäd Rafi, who among other things is an executive advisor at Santis Health. Saäd has held some of the most critical deputy minister positions in the Ontario Public Service, including public safety and policing, transportation, energy and infrastructure, and health and long-term care. During his time at the Ministry of Health and Long-Term Care, he oversaw one of the largest government budgets in Canada, $48 billion. Shepherding the ministry through the challenging landscape after the 2008 to 2009 financial crisis, Saäd also drove impactful change in the realms of infrastructure, digital health, and hospital funding modernization. After leaving the Ontario Public Service, Saäd was named the CEO of the Pan Am Games in Toronto 2015. He reestablished shareholder and sponsor confidence and implemented the largest multi-sport event in Canadian history, returning a significant surplus of funds to taxpayers and increasing the economic activity above normal levels in Toronto and the surrounding municipalities. So a perfect discussant for today with David. And David O'Toole, President and CEO, the Canadian Institute of Health Information, or CIHI. As CIHI's president and CEO, David leads the organization for a few more days in identifying the health data and information priorities for Canada's healthcare system in collaboration with FPT governments and partners. He's been CEO of CIHI since 2014, so a solid decade of impact. Prior to joining CIHI, David held several deputy minister and ADM positions in the Ontario Public Service, including in natural resources, transportation, and the Cabinet Office. David is an adjunct appointment at the School of Public Health Sciences at the University of Waterloo and is an adjunct professor at the School of Policy Studies at Queen's. He's a past chair of Kingston Health Sciences Centre. So without further ado, Saäd to you, David to you. We'll take about 35 minutes or so for this moderated fireside chat. Then we'll come back with questions and we'll work through our time towards 1 o'clock. So very much looking forward to it.
Great. Thank you very much, Ross. It's my distinct pleasure to be able to do this with David, a former colleague and a dear friend. So David, let's just launch in if that's okay with you. And maybe I'll start with asking you about the journey that CIHI has been on during your tenure with the organization. And maybe you can reflect on some pivotal times in that journey. I know it's been a long one, so there may be lots to discuss there, but maybe you can cherry pick a few for us.
Notwithstanding the fact that I'm leaving in July, I've been much more focused in many ways on what the next evolution of the organization is going to be required to be. But I suppose that requires some thought about what's happened in the past. And when I think about the changes in healthcare, in the healthcare systems across the country from when I started, there's been a sea change in one of the things that Eva responded to, Saäd, and that's been the importance and significance of the use of health information and health data to drive decision making. I remember one of the first experiences I had when I came in. I walked into a meeting and with some hospital executives, and one of the CEOs of a University Avenue Hospital in Toronto said, "Oh, here comes the guy who works for the organization that tells us what we do wrong all the time." And so there was a cultural behavior that needed to be transcended, and I think largely as a result of the importance of public reporting of the information and the outcomes, but also setting up the relationships with the institutions so that they weren't hijacking or they weren't ambushing the institutions. We give them opportunity to interrogate the data before the public release, understand the methodology that went into the development of the reports, and how they might maybe use it to improve quality. That's all been part of a conversation, and now we find ourselves at the back end of the pandemic, where vernacular about health information and health data is the subject of conversations around dinner tables. So to me, that general reflection on the significance, importance, and in fact, the literacy, the capacity of people to use and understand data has been one of the most important factors in the last 10 years.
Thank you for that. I think it's not easy to affect cultural change. So, you know, as the saying goes, culture eats strategy for lunch all the time. So how did you maybe just pursue that a little bit? How did you sort of embark on that? And was it a long journey, or was it just a matter of using the data more strategically with your stakeholders?
Well, I think it took a number of different approaches to the use of the information and the data. First of all, that nobody was going to get audited, right? That this wasn't going to be a punitive exercise, that it was to be informed, to inform the decisions around improving safety and quality of healthcare delivery. And that we were a safe space, in a sense, to be able to convene conversations. You know how quickly health conversations around the FedProp table deteriorate because it quickly becomes around money and around some of the scale and the scope. And we weren't hosting those conversations. We were hosting conversations around what should be the health data priorities for the country. And we weren't necessarily always driving the conversation, but we provided that convener role that allowed senior executives from across the country and from healthcare delivery organizations to participate in that conversation. I don't mean by any stretch of the imagination to think that we've solved the challenge. We continue to have cultural impediments to progress that we have to get over, both inside CIHI and in the healthcare systems generally. But I think it's worth highlighting because I'm not sure that we've got the luxury of a lot of time, given the pace at which the imperatives of the healthcare systems are driving costs, the impacts on patients, the impacts on providers, the advances that are upon us as a result of expedited technological advancements, and the expectations of a more literate public as well. So I think we don't have a lot of time to think about these things, or to, I mean, I don't mean ill-considered, but we need to demonstrate that we can think and do at the same time with respect to implementing some of these innovations around health information and health data.
Thank you for that. I like the phrase that the convener role, because as we all know, I think it's a large system and there's lots of silos and there's lots of misunderstanding due to an inability to come around the table. So that clearly has made a difference. As you said, you need to reflect on the past in order to look to the future. So, if you accept that no organization can stand still and be successful, where do you see CIHI needing to go in the future? And perhaps, well, I'll just stop with that and say, where do you see it going into the future? And we can build on that.
Well, so I think CIHI is 30 years old this year. It's their 30th anniversary. So it was an organization that was built in an analog period. Maybe people were using BlackBerries, but to me, the characterization of the challenge for CIHI is, how do you evolve and maintain your relevance and currency and practical application for the provinces and territories? Because we're all paid with public money. How do you change your effectiveness or efficacy and utility in evolving from an analog to a digital era and an analog to a digital organization, from the holder of large administrative data sets that were constructed in different ways at different years to different standards? How do you take that organization and transform it into one that can be used by high-performing healthcare systems and hospitals and primary, like the entire network of care service delivery over the next 5 or 10 years, and not take, like, don't do it in geologic time. That's the other thing. You got to do it in time that's relevant, so that you've got to be, sometimes you got to accept the 80-20 rule, that 80% is what you need to get done, not 100%. So I think there's that. I think we should be able to, we have the luxury, and it's a privilege, to be able to work in this space, and no one's going to die if we make a mistake or if we're late on a report. That's a luxury. So we should be able to use that flexibility in our mandate to take on some of the risk for provinces and territories in terms of proving out the use of artificial intelligence applications. How can we use technology and the optimal use of near real-time data so that we can take on some of that risk and get things sort of what you used to call shovel ready, but ready for deployment into care settings without the 13 different jurisdictions having to do it on their own. Because I am very concerned that as the as we move into this era of greater digital capacity, that the digital divide a dramatic digital divide will continue to exist between high capacity organizations, high capacity jurisdictions where they've got the money, the expertise, and the wherewithal, against those that are receiving care in jurisdictions that don't have that same latitude. And do we have a role in that? I think about that. And the final thing I will say is, I think we need to be thinking about in an age where data is weaponized and an era of disinformation, as a holder of health information, personal health information for Canadians, what role do we have in that kind of dynamic? Do we have a responsibility to correct the record? Do we have a responsibility, if there's an article published that presents one point of view, to point out that there are alternative points of view that can be devolved from the same use of the same data? Those are things that I think CIHI board has to come to terms with, and the staff members, but I also think we have membership of all the provinces and territories at our governance level. That's a conversation that should happen there as well.
So it may be not possible to predict where the greatest impact would be on the system, but is it in leveling the playing field, so that there's as you say, that there's a sort of equality, that your convener role as well as your provider of information is able to allow those jurisdictions with less resources to be at the same level?
Yeah, I think there's a complex set of issues related to technology use, privacy and confidentiality, that would benefit from a very structured continuing conversation between health care providers at the provincial and regional level across the country, where it takes place to some extent now, but I mean, I'd be interested in your views as well. I think the provinces could be better amongst themselves, in the absence of the feds, actually, in sharing information about leading practices, improving quality outcomes, the use of data in those circumstances. I'm not knocking the feds, but sometimes it's an easier conversation when it's just about improving quality of care delivery and patient safety.
Yeah, and I think there are times where that has proved very beneficial. The PCPA is the outgrowth of one of those examples, and I would say on best practices, a lot of that gets shared quite informally, not just in the rotation of PT meetings, but in between as well. And we find that smaller jurisdictions have more degrees of freedom for innovation, and there's much more to learn there than I would say the larger jurisdictions, who are can be a bit ossified when it comes to change management and transformation.
That's interesting, because right now, Nova Scotia, I think, is a really interesting jurisdiction, doing along. So is Newfoundland, actually. So the Maritimes are, I think, generating a lot of innovation in confronting some of the challenges that we're talking about here. Yeah,
in my experience, that's almost always been the case, at least in my tenure.
I'd like to shift Quebec too. Yeah, I should.
Yes, indeed. I think that they have they've been willing to take more, I'd say, risks with how they deliver care and how they aggregate that care. Let's talk about patients. How can the system actually ensure that patient voices are more central to decision making at all levels? I know that there have been some inroads, but I'm pretty sure patient groups would see that there's a great deal more change needed.
Yeah, I agree. I think this particular section caused me to reflect. I think there's been a diffidence around putting patients' representatives on boards at the governance level because of concerns about advocacy dynamics developing, as opposed to, so it's a bit troubling, but I think that there has to be a role for patient voice in developing models of care, in developing public indicators that assess the quality and efficacy of care. They got to be on boards. They got to be on the quality committees. I think they've got to be part of public reporting. You know, they, yeah, I keep saying they, I mean, we are all either former or will be or future patients as well. So the patient experience needs to be thought of, I think, as the astrolabe, like the organizing point around which the care is built and the model of care is built and delivered. And that in turn drives what the data model should look like to provide the appropriate information to the appropriate caregiver or patient at the appropriate time. I think there's a slightly harder edge conversation to be had, Saad, that I think Ewan has been evolving out west, but we are part of and supporting through work with, you know, choosing wisely and resilience. And that is, I'd like to see a much harder edge conversation about the harm that is created to patients in the absence of health information or health data. Like the absence of data at the, all sorts of clinicians can give you anecdotes about people who were imperiled or died or seriously injured. There's different forms of harm that are created by the absence of information and data. And we need that kind of immediacy injected into the conversation to make sure that things, mundane things like the adoption of standards are given the profile that's required to make this dynamic network of health information as effective as possible.
Yeah, great.
Like we're thinking, like I'd love, this is a little controversial, I suppose, but why can't we have an indicator, like an ICD code for harm that is created by the absence of information or the inaccuracy of health information? And so that there's some sort of accountability for linking HIS systems to primary care providers, to long-term care providers, to home care providers. Because that's where I think there's some fundamental progress to be made, and it's a solvable problem.
And what would you say, CIHI, how CIHI has fostered patient engagement and data literacy to really improve that accessibility for all stakeholders? Is there something there that you've done or you wish you'd done and you didn't get a chance to?
Oh, yeah, we've involved patient voice, patient representatives in how we report our outcomes, like the public reporting of how the healthcare systems are doing in various domains. In the last 3 or 4 years, it's been working with Infoway and other PCHO, other pan-Canadian health organizations on the development of interoperability standards, one of the key drivers of which is to give patients access to their own information, whether it's their own direct medical information or their ability to engage with the hospital system by booking appointments, getting reports. So those are meaningful ways that I think, and I'm a little impatient about the progress we're being made, but you know, the federal government's put a fair amount of money into this in the last couple of years, and there is demonstrable progress to be made, I think, in those areas. And we are huge advocates of working with organizations like Choosing Wisely to engage with patients to ensure that they get the information they need. And in our public reporting, things like the quality measures that we report on for long-term care facilities, for example, are used by individuals to decide whether that's where their mom's going to go or not. They can look at things like how the organization is managed, pressure ulcer results, things like that. So I think what the contribution we've made is to assume that a knowledgeable public can interpret and use health information appropriately and make it as available as possible.
Wonderful, thank you. You touched on AI, and you know, everyone is consumed with how to capture the power of generative AI, whether it's the construction sector through to healthcare and every sector in between. What do you see as opportunities for deploying AI at CIHI specifically?
Well, I think there's 2 or 3 things where we could be useful. First of all, we're already in the process of sort of interrogating the AI solutions that are available for improving our own internal human resource functions, communications functions, public reporting functions, finance and accounting functions. And the second one is we've been working with, well, I shouldn't just say the second, but in our external relationships, the distribution of jurisdictions and provider organizations, how can AI be used to make as effective as possible the access to and the use of near real-time data? So we've got something underway which is going to have us getting near real-time, which I mean like last week rather than 6 months ago, by the spring of next year, summer of next year, from a cluster of hospitals across the country. I think that'll drive out a number of questions, Saäd, because the appetite for real-time data, it's not clear to me who needs it immediately. So it'll prove out a bunch of questions. What is the appropriate interval for which information, and who should get it? Who needs it weekly? Who needs it daily? Are we getting to now to, do we then start to intersect with the health information folks who are the HIS folks who are like providing clinical backup every day to the bedside table? So I think about that. There's a couple of things on the health workforce front that are coming together. I think but it's the people who code the healthcare information in the hospitals, often in the basement of the hospitals.
Mm-hmm.
The coding profession is diminishing in people who are, like, there's a fewer number of people who are applying for that. We're working with CIHI on this, but I think about this the same way that we've seen the evolution of the librarian profession. Like when I was in high school, it was Dewey Decimal System and index cards. The library science folks now are knowledge managers who are responsible for managing technology and the interface of individuals. And I think that's where the professionalized in the coding community and dealing with the dearth of coders right now will require the use of AI in the development of automated coding tools, which I know there are firms in Canada and across the world that are doing that as well. But we have to think about that as a material set of activities that we're undertaking with provinces and territories in the next 3 to 4 years, that automated coding can be introduced in hospitals without sacrificing quality and accuracy, or at least having an acceptable like risk approach to managing that, so that the more transactional coding can be done by AI bots or AI machine methodologies, and the more complex things can require human intervention to interpret what they're seeing as they build out the patient record. So I think that one area would help professionalize that sector, deal with the health workforce pressure inside institutions, and I think be an optimal use of the technology in that setting. And we're working quite hard with the fellow organizations on that.
I really like the ambition of taking what you're doing, data science, and taking it right to the bedside. To me, it sort of brings your full circle comment about cultural change and behavior change, and a real acceptance of CIHI as a interprofessional role at the bedside, not just, as you say, a report that has a 6-month age on it. So I really commend you on that.
Well, I think that leads to a whole other host of things. Probably one of your next questions, what do you wish you'd done? So like this is going to require CIHI to change. And we should have gotten on this earlier, but we need a more systematic and deliberate relationship with the private sector and not for profit. We got health information in the epics of the world, Oracle Cerner issues, because we can't do this stuff alone, and we need to pick strategic partners in order to address the issue of standards, because the adoption of standards is what's going to help drive the transformation of hospitals. They are now manifested into where many of the leading institutions in the country are going as deliverers of distributed care. but there needs to be a central repository of that information that's feeding that risk delivery model. And I think private sector partners are something else that needs to be part of this equation to develop, to fully realize the potential of AI. We can't do it alone. I think that the working with the clinical communities as well is going to be part of this. Absolutely question. And I think one of the things that I regret not being able to make more progress on is the $100 billion a year that is spent by the insurance business capturing health information that we don't have any sight into. So it's a third of the spend in healthcare in the country, and there needs to be more collaboration, some entity who can work with the Blue Crosses of the world and the Green Shields and the Canada Life and the Manulife to where can we provide benefit for another, expose, get a line of sight into that health data about the healthcare system as a whole. Because in the absence of that, we only have a partial view of how things are going.
Yeah, indeed. And I think that there are many sort of socially responsible aspects to what you've just said that have to be considered as well, of course. But do you have any advice on what sort of, you were talking about CIHI has to change, an advice on what organizational or structural elements that need to be in place for organizations to better harness AI?
Yeah, it's, well, first of all, God knows I'm not an expert, so this is all going to be based on our own experience and observations. Get your internal data governance house in order first. So that means your practices and methodologies about your data and information shop. If you've got competing data, documentation needs to be in place. I would also say that there needs to be a level set, there needs to be a common vocabulary throughout the organization, from the board right down through the ranks. Understanding the basic concepts of between AI, generative AI, what's it, what are the risks, investment in making as many people as possible familiar with the vocabulary and lexicon of what this is about, so they understand the concepts and methodology, even at the most basic level. Because to me, this is going to be a challenge, the literacy challenge, at a much larger scale. And you want to be in a position to be able to make responsible decisions and know enough about the decisions you're making to actually inform thoughtful decision making, and not leave it to a bunch of people who you trust understand the technology. I feel about that very, very strongly, because sitting on the board of the hospital or being part of conversations about investments of millions of dollars that people didn't, I would encourage organizations to have set as kind of a goal, a basic level of understanding about key aspects of AI proselytized throughout the organization, and not leave it. The risk is you build a priesthood or a small group of people who make the decision, and I think that's not responsible.
Yeah, I couldn't agree with you more, and I really like your point about not just a common vocabulary, but the business process redesign in this area is not going to happen from some appointed czar. It's going to happen from the front lines, where they can best understand how to harness generative AI for improvement in outcomes. And so, really well said. I think those are 3-4 areas that we could all stand to follow. David, let's turn to the personal, and maybe give you a chance to reflect on 10 years is a significant commitment to healthcare and healthcare data management. What were you most passionate about during your leadership journey? I know you've touched on several things in the course of this conversation, but are there a couple things that you want to identify from the very beginning through to what is a stellar career of leadership over 10 years at CIHI?
That's very, very generous of you. Thank you, Saad. I think one of the things that I've contributed most to the organization is the necessity of collaboration and not focus. That success only will come from understanding what the provinces and territories and provider community and patient community want, actively collaborating with them, seeking their insight and advice, but also collaboration with other organizations. When I think back to my first couple of years, CIHI was at risk of becoming very insular, and I think what I've managed to emphasize is the need to be generous in view, pick your partners carefully, but do pick them and trust them. That's what I would say. Things that I feel that has made a bit of a difference in how CIHI, I think we need to continue to work to put the patient and the provider experience, like that nexus, at the center of how we think about care models, and therefore how data flow should be organized to support that relationship. And I think the other thing I would say, and that people who work with me would say, is don't be timid. Don't be timid. We can't afford that.
What would you say has perhaps you've talked a great deal? Oh, sorry, David.
No, go ahead.
You've talked a great deal of what has changed, but are there things that have stubbornly stayed the same? And are they? Is that just the way of the healthcare system, or is it something that has vexed you over your tenure?
Well, you and I used to have these conversations. Like, in some ways, the different healthcare systems across the country are cultural artifacts of the jurisdiction that they grew up with. And the relationship between the providers and the governments in Quebec, in Ontario, and BC is different, each one of those things. And that's frustrating. So I think, and Ontario continues to be, to me, one of the most chaotic jurisdictions in the country with respect to trying to figure out where to get a handhold on something. And I admire tremendously the people who are engaged in trying to improve that healthcare system. I think the reluctance around adopting standards is something that we need to continue to drive. It's been a frustration, and I don't quite understand kind of parochial views that get in the way of adopting a common set of standards on particular things, because I think adopting those standards are what is going to allow the innovations that flower in different jurisdictions that have different histories and backgrounds to be shared. Like, that's what I actually think we need to be able to do, is to allow what happens in Quebec to flourish, but compare what has happened there to what's happened in BC or Northern Ontario or Nova Scotia, and glean the most distilled wisdom out of those things that may have application in other places. But you can't do that unless you're using the same vocabulary, and that's basically what standards are.
I like that. I think you're very, very correct there in terms of the sort of stickiness of not being able to take those on in a common way. I suppose one could suggest that it hasn't hampered innovation, but it may have hampered the adoption across the country in a more effective manner. Is that a fair interpretation?
Yeah. Yeah.
So, David, what advice do you
Yes,
have
absolutely.
for
The scaling and scoping challenge. Absolutely.
Great, thank you. What advice do you have for current and future leaders in the healthcare in healthcare in this country? You talked about standards, and I think that's a very important point because it is pan-Canadian. But anything you want to leave the audience with and others?
I would say be generous in your collaboration with individuals and organizations as well. Take a generous approach to that. Make sure that, as I said before, that the patient and provider experience are at the center of what you're thinking about. Given wherever you sit in the healthcare ecosystem, make sure that that's resident there and it's kind of an organizing principle. And do not be timid. Get your thinking straight, get your house in order, and then act on your decisions with conviction, is what I would say. Don't relitigate things, accept questions, just get a move on, is what I would say.
Oh, that's sound advice. So as I see Ross coming back into our video screen, David, first off, let me thank you for your generous commitment of time, but more importantly, your thoughtful comments and reflections on what has been, as I mentioned before, an impactful career in the health system in this country. And I want to thank you for allowing me to be at the other end of these questions. And I'll pass it over to Ross to get us into the Q&A from the audience listening today.
Great. Thanks so much, Saäd. And thank you, David. We've had an array of questions that have come in, many very interesting and lots of sort of common themes and areas of sort of deeper interest that are starting to come through. So Saäd, I'll pass you a few questions if that still works for you. And
Sure.
I'll encourage everyone who's with us to continue to take advantage of that Q&A function on the bottom of your screens. I'll pop back off screen in a moment, but we'll be shepherding those questions and making sure we get as many of them to David as possible before we wrap this up. So we've still got close to sort of 25 minutes or so, and looking forward to the questions to come and the answers as well. Thank you, Saäd and David.
Okay. Great. Thanks very much, Ross. And David, this first question, I think, picks up nicely from where you left off, and it reads as follows. How can the provinces work together to improve health outcomes? And how can CIHI's role as a pan-Canadian health organization help support and accelerate that collaboration?
Well, this is a it goes back to something you said earlier on about the informal nature of the exchanges between jurisdictions. I think if there was a common agenda established, and perhaps this is going on and I'm just unaware of it, of the key challenges that the individual jurisdictions are confronting, and it may be the same suite of challenges, but to different degrees, like with the same categories of things. If we could work with them to help establish the things that the categories of concern or the categories of challenge that need to be reported upon, or where information needs to be exchanged, I think that we could probably do a better job, not just as CIHI, but bringing in Health Excellence Canada and bringing in InfoWay to bring that suite of capacity that exists in the pan-Canadian health organizations as enablers of making progress in individual jurisdictions. So I think it's not just CIHI. it's that whole suite of PCHOs who've got considerable contribution to make, and they do have the time. They're not dealing with the day-to-day pressures of running the healthcare system. And I think we could, as a group of organizations, work more effectively in a more coherent fashion together to bring a suite of possible solutions to the provinces and territories, or if not solutions, then ways of thinking about improving out different approaches to, for example, building models of care.
Fantastic. Well, then picking up on your reference to PCHOs and specifically Canada Health Infoway, our next question is, what is the relationship that you foresee between CIHI and Canada Health Infoway? And is CIHI aligned on the roadmap that Infoway has laid out?
Oh, yeah, we've actually been part of the roadmap that's been developed. So the way I characterize, so we've been working intimately with Infoway on the development of that roadmap for the last 3 years. And the way that I characterize the relationship is that we each have responsibility for standards. I know I'm beating the same drum a lot, but Infoway's got responsibility for developing the standards around the pipelines that are developed, and we are responsible for what gets flows for the standards around what flows through the pipelines. So they build the pipelines, and we've got the data standards that have to go along with that. And we're working increasingly in complementary fashion to make sure that we're doing this in ways that don't add to the administrative burden on existing jurisdictions right now, but in fact attempting to make them easier, and also to get information into the hands of individual patients and members of the public more rapidly. So I see the collaboration continuing, probably getting tighter, and focused on the issues of interoperability for the next 3 to 4 years, 2 to 3 years, to try to move that agenda forward in conjunction with private sector players like the HIS providers, the primary care platform providers, et cetera.
That's tremendous. That would be fantastic. Let's shift to patients. What would be one thing patients can do to understand and advocate for improved data interoperability?
Well, things like the Resilient Healthcare Coalition are fantastic for getting the patient voice. I think, as I've said before, I'm a very, very strong believer in the importance of public reporting in terms of public accountability to politicians and to senior officials and executives in holding the system to account for its successes, and it's working with the patient group and the patient community to develop different forms of public reporting, not always necessarily indicators, but getting the patient view of the adequacy or inadequacy of care in a particular domain or sector as high a profile as possible. I would like to see, and this is one of the things that I regret not doing at CIHI, but the patient voice, go to journalism schools, make presentations at the School of Journalism, at Carleton or wherever. Get your story out there so that the people who are then, because the reporting community, people like Andre and others, they've got a really important role in kind of consolidating the patient view of things, and let's broaden that out so that there's a broader canvas on which the patient experiences of various kinds, good and bad, are reflected. I mean, we've been working with Avis Favreau inside CIHI to develop podcasts, several of which have had the patient experience at the center of them, and it always is impactful. It is always impactful to get that out there. So I would think about some of those less orthodox ways of not just board membership, but getting the patient experiences into the vernacular of how healthcare is delivered on an ongoing basis.
Yeah, I couldn't agree with you more. And as I say, sorry, as you said, this has to go well beyond at the board level. I think it's fantastic to have patient advocates or parents of patients in my own experience at Sick Kids on the board quality and safety committee. They're fantastic contributors. They tell you that, look, that doesn't work. What you're proposing is really sounds really lovely, but it's not practical, or whatever the case may be. But you're right. I really like the journalism example. That's a tremendous one. Moving to the next question. Can you recall and describe a story where you were proud of at CIHI, and what is the best data impact story you can share with us?
Oh, well, what I'm proudest of was how quickly the organization responded to the changing needs of the healthcare systems during COVID. There was 2 or 3 things happening simultaneously. There was different reporting requirements that were issued on a dime. We had to turn on a dime from the feds in the provinces and territories because they were convening, sometimes 1 or 2 times a week. But it became almost immediately apparent, Saäd, that the information that group of deputy ministers and senior ADMs wanted was not available. And it wasn't because anybody was doing anything wrong. It's because we've ignored the requirements of a well-functioning health data infrastructure in the country for like 30 years or 40 years. And so in response to the requirements of the people making decisions about resource allocation and capacity challenges across the country, we were able to put together a set of basic reporting information and analytics that were used very quickly on a regular basis by the decision makers and had us interacting with the provinces and territories. I would hope the next time around that the infrastructure is in place to provide that in a more fluid fashion and a more systematic fashion, and doesn't require heroic efforts to have those things in place. But I'm really, really proud of how the organization responded and how it changes internal decision-making processes to support that work as well. I think the single most impactful use of information and data that I can recall is shortly too publicly reporting on the use of information and data in the care and long-term care facilities. And along with HEC, we publicly reported the use of chemical constraints in long-term care facilities across the country, and it was pretty shocking. It was clear that health workforce challenges and other forms of constraints were requiring through the use of antipsychotics when no psychosis was indicated in their diagnosis. And within 6 months of that report coming out, people were going onto the website going, I'm not sending my mom there. And they were actually asking questions. And it's again, that's where the public reporting has a significance. People were confronted with the evidence of managerial challenges that were not being dealt with properly, and then behavior.
Yeah, I distinctly remember that report. The next question, David, is what are your thoughts on allowing broader access to CIHI data by industry or other stakeholders?
Oh yeah, I think yeah, for sure. Like I think we have a network of flowing health information that is available to the innovation community, the clinical community, the research community, the policy making and program design community and the members of the public. That's how I see that. Well, not that I'm here for that long, but I see the environments of the country being shaped. Like Saad, you and I used to talk about this. I view it as a utility with the same significance and importance as a transportation system or a power network. The information should be available to an array of users in as fully formed and high quality capacity as possible. And we need to think about what establishing that network will require so that CIHI becomes a node and is ingesting that information and producing reporting or indicators for particular uses, but it isn't, you collect it once and you use it as many times as possible.
Right.
And I think we have a responsibility, like just thinking about the apps that are being developed by clinicians in health research centers across the country that have an angle to them, or like I think have the priority, not just as a country. And
yeah, we might be having some connection challenges, but I'm going to press on with the next question. Hopefully, you're still able to hear me. What do you see as CIHI's role in addressing health equity? Specifically, what do you see as future priorities and activities related to health equity? So CIHI's role and then future priorities all around health equity.
Yeah, we need to continue to report on health equity because it became glaringly obvious during the pandemic that the negative impacts of the pandemic were differentially felt very across different people. First Nations, Inuit, and Métis, in order to mitigate the effects of the unequal effects of the inequitable distribution of the effects of healthcare delivery, and that you need to be able to, and data that you might not have done 20 or 30 years ago. That's to me is one of the other things that changed so quickly as a result of the pandemic was the whole discussion about, just as a person who learned on the job over the last 7 or 8 years, there were so many times when that whole subject about collecting racialized data, what they do in the States, was like a third rail conversation that just got shut down. And then within 6 months of the pandemic, or 4 months, the dramatic negative consequences on different segments of the population in our society was so glaringly, yeah, we got to collect racialized data. So I think we've got a real responsibility to help figure out how to report on inequities of different kinds, whether it's racism or economic disadvantage across the healthcare systems in the country. And we have done that. We've done some good there. Like CIHI, I'm very proud of the fact that we developed a standard for developing for collecting racialized data. And again, it's not a conversation you have on your own.
Okay, maybe I'll maybe look at one more question here, because they're coming in and they're fantastic questions. So thank you everybody for contributing. If you could have done one thing differently at CIHI, this is a nice one, Dan. What would have that been?
Well, I came from being a provincial deputy minister and a civil servant, and a tradition of civil servants that you didn't avoid the spotlight, but if you were in the spotlight, it was decision-making in behind the scenes, work with your team to get the people in place and get the things done, the actions required that were needed. That turned out to be a bit of a mistake because I wasn't as comfortable personally, because like I'm an introvert, believe it or not, with taking public stances on things. And if I had done that earlier, I think it might have been to the organization's advantage. So I don't mean marketing per se, but I mean more publicly available in settings such as this to talk about what we do, why it matters, how it can improve, its value to Canadians. I should have started that earlier. And I think it would have served to move some of the things, the relationships that exist now.
Well, that's fantastic. Thank you for being so open with that answer, David. That's tremendous. Okay, I'd like to squeeze in one more. What would your message to the new CEO for CIHI be, and any lessons that you would like to share?
The new CEO?
Yes.
Trust your team. They're all great, but don't become captive to them. If there are practices inside CIHI that you think don't make sense in the first 7 months, it's not because you don't understand. Develop relationships with your CEO colleagues, not only within the PCHO community, but with other organizations such as this. Cultivate relationship with the private sector and the privacy community. And have fun. Like, don't forget to have a laugh once in a while. I mean, a sense of humor is fairly important.
Fairly important indeed. I think that advice would benefit any new CEO in any sector, David. So with that tremendous feedback from our audience and your willingness to hang in and answer a variety of questions, we'll conclude, and I'll throw it back to Ross, who will introduce some individuals for concluding remarks. But again, thank you for your time, your wisdom, and your willingness to be very open with this group, David. And congratulations on a wonderful career.
Thank you very much, Saad. It's a real privilege to have you having accepted to do this.
My pleasure. Ross.
So thanks so much, Saad, and David. Thank you for being with us in this way and for being as open and as thoughtful and as honest. For those who want to take another crack at hearing David's remarks and reflect on everything he had to share, this event is being recorded, and there will be a link shared with you in the next sort of 24 hours or so. So thank you for your real-time participation. Those of you who started and are still with us, there will also be an opportunity for folks to come back to these remarks and reflect on them in the future as well. So now I'm going to take this opportunity to pass the microphone to Louise Binder, who's a policy consultant at the Save Your Skin Foundation, a member of the Resilient Healthcare Coalition's steering committee. And Louise is going to offer some final thoughts and some closing remarks, and then I'll take the microphone back for just a brief pivot to the next RHC event that we'd like to let you all know about. So Louise, to you.
Thank you very much, and a special thanks, of course, to David and Saad for this remarkable discussion that we've had. There's no doubt that it is an important and timely conversation indeed. And I'd just like to reflect on a few things that I think I heard as key takeaways. First of all, there's no doubt data and AI are here and growing, and have a huge potential as important tools in many areas of healthcare, from administrative tasks to the application of medical decision-making and activities. And we need to ensure it's used as the amazing tools that these can be. We need to ensure that it is created so it can meet its full potential now and into the future. That includes building it as well as we can from the outset, with the best inputs we can develop and with the flexibility to change and to add on as it evolves, recognizing diversity, equity, and inclusiveness in that work. We also need good data for good AI. And that's based on a strong foundation of data standards, that is, structured, comparable ways of capturing things, and governance around the data, that is, good stewardship. We must build those tools without risking patient confidentiality, privacy, security, and we must do so ethically with access to consent as always as appropriate. I'm pleased to say that I've been invited to be part of this work with a totally devoted group of incredible people, both at the policy and development levels. This is a time of huge change and opportunity when it comes to optimizing the use of data across Canada. And it will be exciting to see where CIHI goes from here as one of the leaders on that journey. Examples of data changes and opportunities arising from the Pan-Canadian Health Data Strategy include the need to design our system and data infrastructure to put the patient at the center. For example, engaging patients and Indigenous populations around the design of data collection and reporting, it's foundational to addressing the key equity issues that are important. Also, the importance of building trust and data literacy with a very engaged public, providers, and with the public and private partners in the health system. Canadians expect their health data to be connected, to be securely and appropriately shared. And last but not least, the Resilient Healthcare Coalition. I'm very proud of the role that we've been able to play in hosting system leaders for candid conversations like this one, and convening multiple audiences to participate as we have done today. So I would like to end by thanking you very much for joining us today.
Louise, those remarks were perfect. Thank you. And thanks for highlighting the Resilient Healthcare Coalition. You talked about our goals, and I'll reiterate them for the group that's gathered here today. It's optimizing the use of healthcare data for better decision-making across healthcare systems in Canada, and it's accelerating access to innovative health technologies. The relationship between data and access is an increasingly important and profound one, and we're very pleased that we can be a small part of that conversation to make sure that all of the different worlds are connecting in ways that optimize their impact and their collaboration. So with that, I will free you all to the rest of your days momentarily, but I will take one moment to use the captive audiences that I have to just call out the next Resilient Healthcare Coalition event on June the 12th. It's called Accelerating Patient Access. It's the progress and possibilities of innovative payment models in Canada. So these are ways in which you can find better use of data to reduce uncertainty, ingenuity, innovation, and creativity, all designed to de-risk and accelerate earlier access to innovative technologies, in particular innovative medicines, to Canadians across the country. We know this is a subject of interest to a great many of you. It's a great interest to the Resilient Healthcare Coalition, and we have some fantastic speakers who will be joining us, including Alison Wills from 20 Cents, Andrea Masters from Hoffman LaRoche, and Raylan Douglas from the Government of Saskatchewan. So details to follow, information to come, and we hope that many, if not all of you who joined us today, will come back and be a part of our next session on June the 12th. Thank you all for participation, for your engagement, for your questions, for your enthusiasm. David, thank you for your candor and your insights. And Saad, thank you for keeping a firm hand on the tiller through all of this. We wish you all a wonderful Wednesday and we'll see you all again soon.